Immune-Mediated thrombotic thrombocytopenic purpura is a rare disease, and it is caused by autoantibodies against ADAM13. Therefore, immunosuppression has an important role in the treatment. Mostly we use nowadays routinely rituximab, which is an anti-CD20 monoclonal antibody, and it is really effective in the acute setting as well as in the preemptive setting when ADAM13 level is low without clinical symptoms being present. And although rituximab is effective and safe, there are some patients where it is not working perfectly. 60% of the patients are only responding temporarily, so they will need treatment later on. And 10 to 15% of the patients are refractory to the treatment. There might be also side effects that might contraindicate the use of rituximab, and therefore other treatment options are needed. The problem is that there are not many clinical studies in TTP because it's a rare disease, and also if there were some clinical studies, usually they were performed long ago before the routine use of rituximab. So we need new treatment options and hopefully in the future new guidelines what to use in TTP. In the study, we wanted to know if obinutuzumab, a new anti-CD20 monoclonal antibody, is effective and safe in TTP, in rituximab refractory and intolerant patients. There are some encouraging data in iTTP with obinutuzumab, but mostly in the rituximab intolerant patients. So we wanted to know if it works in intolerant and in refractory patients. So we collected data from the French National Thrombotic Microangiopathy Reference Centers registry, and we collected data on 60 obinutuzumab treated patients. These patients were almost half refractory or intolerant to rituximab previously. These patients were pre-treated patients, so they received the median 3 previous lines of therapies. All of them, of course, received rituximab previously. The most of the patients received this treatment in the preemptive setting, and some of them in the acute phase, and in some cases they received other immunosuppressive therapies concomitantly. We found that obinutuzumab was really effective. In 85% of the patients, we reached an ADAM13 response, meaning that they reached an ADAM13 activity of at least 20%. And in 72% of the patients, of all patients, there was a normalization of ADAM13 activity after the administration of obinutuzumab. We found that patients who were previously refractory to rituximab were more likely to be refractory to obinutuzumab too, but still, even in the rituximab refractory patients, obinutuzumab was effective in 77%. The relapse-free survival median was not reached with a median follow-up of 11 months. Only 3 patients had a relapse. One of these was a clinical relapse, and 2 of these were ADAM13 relapses. Regarding the safety of the therapy, 11 treatment-related adverse events occurred, and none of these were severe. We haven't seen any surprising adverse events. Most of these were actually treatable, manageable infusion-related reactions. So based on these results, we think that obinutuzumab is really effective, not just in previously rituximab intolerant, but also in rituximab refractory patients. I think the most important thing to continue with is the longer follow-up, because obinutuzumab is really effective. We know that from other diseases, mainly from B-cell malignancies, that it can be used safely and effectively. But in TTP, the follow-up is quite short, so we don't really know the long-term safety of the therapy. So I think that is one important point. And the other question regarding the therapy is that the schedule of administration and the optimal length of administration is not very well defined. So hopefully with more data, longer follow-up and more patients, we will have more information in this topic. Also, the problem in TTP treatment is that after rituximab administration, the further therapeutic lines are not very well defined, and there are no clear guidelines about for these patients. We think that based on our results, obinutuzumab might be an optimal first choice in cases of rituximab intolerance and refractoriness, but further treatment lines are still uncertain, so we will need further data and clear guidelines to decide about the optimal treatment sequence.